Good evening and welcome. I'm Nora Kane. I'm the director of the Stanford Health Library, and it's my pleasure to welcome you all here on this very rainy night. It's wonderful that we have an audience here. For those of you who are at home, you're lucky you're at home because you didn't have to come out in the rain. But for those who came, we are very grateful that you're here, and thank you for coming. It's my pleasure tonight to have Dr. Bryant Lin, who is one of our most favorite speakers, and he appears on our video screens quite often because he always has wonderful topics. And Dr. Lin is a clinical assistant professor of medicine here at Stanford, and he is also the director of the consultative medicine clinic here at Stanford and is in internal medicine, located right upstairs from the health library where we are tonight. Tonight he's going to talk to us about a subject that I think is really important to a lot of people, which is aging at home with chronic disease, and he's got all kinds of interesting new things to talk about. So I'm going to turn it over to Dr. Lin at this point and let him have the floor. Thank you, Dr. Lin, for coming.
Perfect. Thank you so much, Nora. Thanks for coming out on such a rainy day. I know I was drenched earlier, so appreciate your time and attention. Hopefully it'll be drier by the time this is over. Not that I'm speaking that long, so it's not a promise. So talking today about aging in home with chronic disease. This is a topic near and dear to my own heart, both as a clinician but also as a son of aging parents. And I also, as part of my clinical duties, I do home visits about once a month with the residents. I go on home visits with the residents, medical residents, and medical students. So I really appreciated how knowing the home situation is very important for the clinician, for the family, to really understand what's going on at home. So I struggled a little bit kind of when I was making this talk. This is the first time I've given it. Usually I've given a talk many times by the time I get here, but actually I devised this talk specifically for you guys, and actually I will give it, I think, up at the JCC in Foster City in a month or so. But I struggled a bit exactly how to cover the topic. It's a difficult topic to cover, a lot of areas, challenging, especially talking about chronic disease, talking about technology. So I decided, well, because the audience is wide and varied, let's kind of go through all the segments and dive as deeply as we can, but really put it in the context of chronic disease. So today we'll talk about many aspects. So I have the learning objectives here. It's a little hard to see. There's so many learning objectives. But we'll talk about many aspects of aging at home, and also transitional care in the hospital and transition from home to assisted living, nursing home, anything like that, if that may happen, and also end-of-life planning. So we'll go over that today. I will talk about it in the context, just one disclosure, I'm working with a company, Zing Health, which is working on care coordination, especially for seniors. They're using some technology that will enable better care coordination among seniors and among people with chronic disease. So let's get started. Just a little fun kind of art exercise. I know I've done this past couple of talks. So do you guys know who this is? Yes. Well, don't say anything. I'll flip through. Anybody else? Added? Anybody else? Anybody else? Anybody else? Who is it? That's Rembrandt. So Rembrandt was probably the first selfie taker, but instead of the phone, he painted self-portraits. So, and luckily he lived for, at that time, was quite a long and somewhat stressful but fruitful life as a painter. But because of that, we can see how he aged. And also we can not only see how he aged, we can see how his interpretation of his age, of himself changed over time. So I thought that was fascinating. I spent my sabbatical a couple of years ago in Europe, and we had the luxury of being able to visit some of the world famous museums. So I was able to see self-portraits kind of scattered throughout Europe. And it's kind of interesting when you spread them out in such a context of aging and to see what happened to him. So that's how I wanted to start the talk. I found this interesting column in The Guardian. It's a British newspaper. And the columnist said, while other artists were coldly curious, or worse, cruel in their depiction of old age, Rembrandt relished the effects of time. So I thought it was an appropriate way to start a talk on aging, about aging gracefully, and how he appreciated the benefits of aging as well, at least in our interpretation of his paintings. So in the talk, when I sent Nora the description of the talk I was going to give, that was before I actually made the talk, so it's kind of in my mind at the talk. And I really wanted to give the talk in the context of chronic disease. And for many reasons. So chronic disease obviously will affect every aspect of aging. So it's really, I put a magnifying glass here. It really magnifies and distorts and changes the process of aging. So you really need to be aware of the context of chronic disease when we talk about aging. But I also wanted to talk about chronic disease because this is something we all deal with, and as we age, the way we deal with the chronic disease may change, and how we interpret and what our goals are with the diseases may change. So you really need to think about everything I'm telling you, and again, I had difficulty kind of deciding how to best structure this for a wide audience, and I'll introduce different aspects and different functional parts of aging with chronic disease. So we'll talk about that. But more from a functional status. So I always like to start with mobility when we talk about any disease, but especially aging. So this is a statistic that I think shocks most people. 1 out of 4 people over 65 fall every year. That's incredible, 25%, a quarter. We could do the thing where look to your left, look to your right, look, one of you is going to fall, at least one of you is going to fall this year. Most of those are minor falls, of course. 90% are probably minor falls. People trip, people, accidentally fall, they slip. In a day like this, very easy to fall. But 10% of those can result in significant injury. Head injury, hip fractures, vertebral fractures. I mentioned this is near and dear to my heart as a son. My mother, 4 or 5 years ago, fell down and she had a vertebral fracture. Of course, she blames my dad to this day for this because they were playing badminton. And I think he ran into her or something going for the birdie, so she fell down. So that happened. But it can happen to all of us. It can happen when you're younger, but if it's a more common occurrence when you're older. Why do we fall? So this is something that is not well appreciated, even among the medical community. So we lose strength. So that's something we know, but we don't appreciate in the context of falling so much. And especially proximal muscle strength, the large muscles, so your quadriceps, your ability to get up. So what does strength have to do with falling? Well, if you can't compensate for imbalance, then you can fall. Even though you realize you're falling, you can't react to it. Poor balance is also well understood. So this is one thing that most providers and patients don't appreciate this. Sometimes it gets buried down in, when you remember for physicians, when you remember back to medical school, there are actually 3 systems involved in keeping your balance in terms of understanding your balance. So your vision is very important, right? We see what we're seeing. We know, if we're moving around, that helps, right? We use our eyes to help compensate. So when it gets dark, it can be more difficult to balance. So vision gets worse as we all age. Proprioception. So what's proprioception? That's the ability to sense what position your joints are in, even without looking at them. So that changes when you get older. That's known to decrease when you get older. We don't know why that's the case. And then vestibular dysfunction, that's your inner ear. So that also gets worse when you get older. So that all 3 of those systems that assist your balance, they all get worse when we all age. So that's just a triple hit. So this is why it's not such an easy problem. We have a program here, medical device program called the Biodesign Program. I went through it about 11 years ago, and they're looking at aging, in particular falls, this year as one of their tasks to look into the needs and to explore how they can address the needs there. But it's been a tough one because it's really hard to address because there's so many causes. Anytime there are multiple factors causing a problem, it really makes it much more difficult to address. Of course, there are medication-related issues. Some medications can cause your blood pressure to be too low, your sugar to be too low. So that's especially important in the context of chronic disease. When you're hypertensive, 60 plus million Americans are hypertensive. Blood pressure medications are a well-known cause for people to have low blood pressure when they stand up, and that's a very common cause of falls. Of course, diabetes, low sugar can cause it. If you have too high sugar, you can get dehydrated and you can be more likely to fall. And then specific disease-related instances. So infections are a big one that you have to be aware of, especially as when we get older. Infections can cause you to have difficulty with your reaction time, difficulty with your thinking, and falls can be associated with that because you're just not feeling well. Anybody who's sick is just not feeling well, so you react slower, you're just less able to compensate. Of course, pulmonary disease, COPD, diabetes, heart failure, your heart's not working well, you get short of breath, but also you get edema in your legs, you get swelling, and your legs feel like a ton. I was talking to some students, more engineering students, about aging and edema and falling. I said, geez, you could just try strapping 10-pound weights to each of your legs, and maybe you'll know how it feels. So, and then imagine other things. I didn't list other diseases like osteoarthritis. So if you have chronic knee pain, chronic hip pain, that can affect falling too. Any pain, any instance of pain. So how do we improve mobility? I just said that it was a difficult target to hit. We don't have any magic cures. Of course, treating underlying disease is important, making sure the medications are well managed, they're well titrated. But physical therapy is really the mainstay of treating falls. So we have a program here called Farewell to Falls out of the emergency room. It's run by the trauma service. So if you've fallen within 30 days, they'll have you, be evaluated at home, occupational therapy, physical therapy, evaluate you for assistive devices. So these are all good things to improve your strength, but also, to do exercises to improve your balance as well. There's some evidence behind that. So these are evidence-based things. Assistive devices are important. There's variable usage and variable ability to use these assistive devices. If you look at canes and walkers, about 6.5 million Americans use walkers and canes. Of course, doesn't mean they use them every day. They could use them sporadically. I know, again, personal case of, among my patients, but my mother as well, she really doesn't like using her cane or walker because there's a stigma there, right? You feel like you're getting older. You feel like it's a sign that you're getting older. So she really refuses to do it. But that's important. It's an important way to improve safety. So these are safety devices. Wheelchairs are also very common, 2.2 million Americans. That includes transport chairs as well. And there are other assistive devices for people, electric scooters, electric wheelchairs, lifts for people who really have difficulty with mobility to move them, and transfers. So I get this question a lot, walkers. This is a big kind of, if you don't have a walker, or even if you have one, it's unclear what type to get. What do you do with it? There are all these newer walkers, lots of bells and whistles. Let me preface this a little bit. So there are several types of walkers. There's a standard walker. So this is not even the standard walker. The standard walker is the old four-legged walker you took with you, you moved it. So that was the first walker. Then they added 2 wheels because they said, geez, people have a tough time with their upper body, so let's have them scooted along. Then some clever people started to put tennis balls, those little, open tennis balls, those cracked open tennis balls in the back because they said, geez, I still have to lift up the back and that's hard, so I just want to push it along. And then they developed the 4-wheel walkers with brakes. So those are, some people call them rollators, and a lot of times they have to get chairs and they've got lots of bells and whistles, they've got little pouches, places for you to put your bag. So these are all different types of walkers, and sometimes if you just go to CVS, you probably will end up with this walker. So to get kind of the fancy walker with bells and whistles, you got to go to a medical equipment store. So the challenge is now, Medicare has changed their process. So now it's much more difficult if you have Medicare to get a walker because you can only go to a very few medical equipment supply places to do this. So only the people who kind of won the bidding process are approved vendors. So a lot of places are either cash, and you can tell they're cash because they're in a nice place, they've got a nice storefront, and it's a retail business. And the Medicare suppliers usually are in a not so nice place. You don't even see the store, and they come to your house, they put it, they teach you how to use it, which is all covered by Medicare, but it can be challenging because sometimes you need a physical therapy evaluation to get one reimbursed. But it's important to make sure you get one that's suitable for you, one that you like, one that fits your requirements, one that's not too heavy. I mean, remember, even if you have a walker, if you have a car, you got to put it in and out of the car, right? So if it's heavy, it doesn't fold up right. If you don't like how it folds, it may not be the one for you. So it's worth spending the time to shop for this, either for yourself if you're using it, or for whoever you're caring for, to really spend time to shop and make sure you have a good one. Make sure you like how the brakes are working, all of those things. I'll go over a couple of details now. This is from Mayo. They have a great site, and you can look at the website below. If you just go Mayo and walkers, they have a nice kind of intro guide to choosing a walker. But you wouldn't think there were so many factors. There are different grips, right? Plastic, foam, soft, depends on size. There could be bigger grips, smaller grips. They're made of plastic, they're made of foam. So if you've got sweaty hands, sometimes the plastic ones are too slippery. If your hands are too small, you may need a smaller grip. So these are important factors because if you can't grip, it's not going to help you, right? Choosing the correct grip will relieve unnecessary stress, because if you have the wrong size grip, you could be gripping too tightly and then you develop hand pain. You're like, why am I developing hand pain? It's because the grip may be wrong. And make sure it doesn't slip around. Make sure it fits well onto the walker. And this is something that is kind of a pet peeve of mine. A lot of times people don't bother to fit their walker correctly, so they don't adjust the right height. They're using it incorrectly. So again, this is from the Mayo website. I think they did a good job explaining it. Make sure that the arms fit your arms correctly, 15 degrees, so you don't want like this, and you don't want to be leaning way over. That's a big problem we see people do all the time. This is an assistive device. You shouldn't be relying on it 100%. So try to stay upright as possible. And you see that over years. People start leaning further and further and further over, and that's really dangerous. And that puts you at risk for falling. You can check your wrist height, check your elbow bend, and make sure the top of the walker, kind of lines up with the crease of your wrist. So walker technology has not really changed, I hate to say. I actually worked with a company a few years ago. I have an engineering background, so sometimes I do some consulting for these types of companies. And they had a difficult time because it's a really tough area to really improve on these walkers, because there's so much customization that you need to do. It's hard to do have a one-size-fits-all walker. But important thing is make sure the weight is appropriate, because you're already getting it in and out of the car potentially, or somebody's doing that for you. You don't want them to hurt their back or twist or anything. And make sure it fits in your car. If you're going to carry it around, if you've got a small car, it may not fit if it's in the right dimension. So I didn't list all the steps because it's more time than we have today. But how you use a walker, you push it in front of you with just one step, and then you walk up to it. As opposed to rolling along with it. That's why it was originally made as no wheels, because they wanted people to lift it up and put it down, and lift it up and put it down, because it's a fall prevention device. It's a safety device more than anything. But if you want any more details on fitting the walker, the Mayo website's an excellent one. Really reasonable details. Not every website is good about this, but I felt the Mayo one was a good one. So mobility kind of naturally leads to activity, right? So activity is good. I think maintaining mobility through exercise is really one of the few things we can do in our lives that we have control over. So it's both not just walking, but and aerobic exercise is good. Walking, running, cycling, low impact is good for the joints if you have arthritis, but also weight bearing. So we all lose muscle mass as we get older. So you got to do some weight bearing exercise to maintain your muscle mass. Hospitalization, so this is unappreciated. Lots of medical literature on how one hospitalization can really impact your mobility. Even one day in the hospital for an older person, you can be really deconditioned. So you got to be aware of this. There's lots of reasons. People don't like to walk in the hospital. Fear is number one of them. So there was a study showing that, why do people not? Well, fear was number one. Other ones sort of related to fear. They thought that something about their disease was going to get worse because they're walking around. Almost everybody would encourage you, unless you had a recent surgery and you're not supposed to walk, to be more mobile in the hospital. But it's a scary place. This is why we in the U.S., try to get people out of the hospital as soon as is reasonable. Pain control is important. So if you're in pain, you're not going to be able to exercise, right? So choosing the right exercise that limits the pain for you. So this is why I frequently recommend swimming. It's usually an exercise that, if you have access to a pool, tends to elicit less pain for many people. Cycling, either a stationary bike or an active bike. But it's important, and important to talk to your doctor about how to manage your pain and be on an appropriate pain regimen for you. Physical therapy, of course, can improve strength and get you back to activity. And there's a lot of skepticism among some patient groups with physical therapy. my argument is it's probably not going to hurt, and it likely will help. And if you go to a good physical therapist, they will probably help you target and tell you what you can and cannot do and spend a lot of time with you. Also underappreciated is that some people really qualify for a home PT. If you're homebound, if you can't leave the home without significant assistance, you may qualify for a home PT because a lot of people say, geez, I can't drive, or I don't drive, or it's too far away. So physical therapy is accessible, and Medicare covers it up to a certain number a year. They're typically twice a week, so this is another mistake I see people make. Usually you see them twice a week, but people stop they don't do their exercise between the times they see the therapist. It's sort of like school, right? It's the procrastination. Oh yeah, my teacher's not here. You got to do the exercises as much as you can as per their instructions. That's really important. And then occupational therapy, this is something that I know even medical professionals always get confused because when we're in training, we just write referrals to PTOT, physical therapy, occupational therapy. We kind of lump them together. But they're very different. They really focus on assisting with activities of daily living. They assist with a lot of, helping you choose the correct assistive devices. Some of them work on, prosthetic types of work, but they are more functional in terms of how you live your life. So you can think of them differently. Physical therapy is a little bit more functional in terms of your body. Occupational therapy is more functional in terms of how you're living your life, doing transfers, getting in and out of the wheelchair, that kind of thing. I mean, they're overlapping, of course. So let's talk about the next big factor. So mobility always comes up with aging, but of course memory loss. That's kind of a huge one that looms over everybody. I think there's a little bit of an assumption that we all have loss in mobility, and there's an assumption that we all have some memory loss, but there's this great fear, I think appropriate concern of dementia. So let's talk a little bit about that. So memory loss, when do we start caring about it? Well, there's kind of the normal short-term, geez, I went into a room and I forgot why I went into the room, right? So there's kind of this fuzzy line between what's normal and what's not normal. So mild cognitive impairment is kind of that step beyond just forgetting your keys, forgetting, geez, what was that guy's name again, and remembering it a minute later. It's a little bit beyond that, but it's before dementia, so it's when you still have preserved function. Right? So you're still functioning as you normally can. It's 14 to 18% prevalent, so quite prevalent. And the biggest concern of this, obviously you do have a little functional design, but you kind of still do your normal activity, but it's a really high risk. Most people who develop mild cognitive impairment do proceed to develop dementia. There's lots of types of dementia. Probably, I think, from the patient's perspective, honestly, because we don't have really treatments targeting each of these, you can kind of think of them as all dementia, but you shouldn't say it's all Alzheimer's dementia. So that's another thing I hear, like, oh, it's Alzheimer's. There are different types, just be aware of that. And there's a huge growth in dementia cases. You can see in the Americas, it's going from 9 to 31 million by 2050, increase all through the world. Probably because, of course, our population's aging as well, but so this is old data. There was a recent study that thought there may be a little decline recently in dementia. We don't know why. So that may change. That'll be interesting to see. So it's often not self-reported. So this is really having family support, social support at home. It's not uncommon that it's the family member, the caregiver who reports their loved one's decline in memory. So you can see how it reflects itself. They have a difficulty learning new things. So new information is just hard to incorporate. Like new events. Geez, they went to eat last night at a restaurant. They don't remember they ate at that restaurant last night. As opposed to, geez, what was the name of the restaurant? That's but some, with dementia, you just don't even remember you went out to eat. Language difficulty, so difficulty finding the appropriate words to use. Of course, there's kind of normal of that. I frequently can't find the right word, but it's a really extreme difficulty that makes it difficult to communicate. People with high kind of what we call premorbid intelligence can cover this up quite well because they have such a big vocabulary. So losing the vocabulary is less noticeable until they lose a lot of vocabulary. Behavior change. So this is frequently, and I think underappreciated, first sign of dementia. People start to do odd things, strange things. They could do that and not have dementia, so it can be difficult. But there can be a behavior change, paranoia, concern about other people, that are trying to do bad things to them can pop up quite frequently. Reasoning, especially if things are unexpected, out of the ordinary, that can be impaired. Difficult coping, difficult reasoning through logical tasks, complex tasks, checkbook finances, and spatial ability. So losing, getting lost, physically lost, geographically lost. So how do we make a diagnosis? So we have some screening tests. Mini-Mental, MoCA are kind of some of the most popular ones. These are really short tests. This is just a little snapshot of the Mini-Mental. You can have, they're testing different parts of cognition, certain spatial aspects with the drawing, memory, instruction following. These are very coarse measures. Neuropsychological testing is a little more in depth. Not everybody everywhere has it. Several hours of testing. They bring you through a battery of standard memory tests and cognition tests. Because sometimes it's important to differentiate between dementia and other diseases like depression, which can appear in a similar way. Imaging, if there's concern for vascular dementia, so blood flow, previous strokes. And then, B12, folate levels, so sometimes that can present as a dementia-like illness, but it could be B12 deficiency or hypothyroidism. So those things are definitely important to evaluate when there's concern for dementia. So there's really no curative treatment, as you know, for dementia. Really the mainstay of drug treatment are cholinesterase inhibitors and memantidine. So Aricept's kind of the famous one by brand name, and Namenda. And these can be used in combination. Yeah.
There was a research last year from Bach Institute and UCLA claimed in a small group study for the first time they can reverse dementia.
Yeah, so there are a lot of little studies. So there's no large-scale studies that I know of that really have been shown to reverse dementia as it occurs. So there are some evidence now that if you take people at risk for dementia, there are some things you can do to prevent it. And that's primarily exercise. So they've looked at things like vitamins and supplements, and none of the large-scale studies. This is the challenge with medical studies, right? You really got to do a placebo-controlled trial. It's got to be large enough to give you a statistical effect. One of my colleagues who's retired ENT, used to be the acting head of the ENT department here, he always jokes around and says, there's a study about everything. So, what you really want to look for is consensus. I'm not familiar with that study. It may end up being true, which is great, but, time will tell, right, with research. Research studies always take their time to, you got to do another study and another study and another study. So that may be true. I'm not familiar with that one. Yeah.
It's a combination of lifestyle intervention. I don't know if there's a medicine involved. Yeah. It was lifestyle intervention.
So they did big studies on exercise. They've done several. I'm not sure what that. They've done huge studies on exercise with people with dementia. It actually hasn't shown a benefit if you already have dementia. So the only one recently that's shown is people at risk of dementia. Sorry.
Can you delay it by constantly challenging your brain to do new, more complex things?
Yeah, so there's a lot of disagreement about that. So there's no consensus. So definitely there are companies, who sell these products, there's definitely no consensus. Typically, the standard orthodox answer to that question is, well, usually when you're doing that task, I think most people will say, do it. It's a good idea because you're just, doing something interesting and activating to your brain. But whether it delays or defers dementia, there's evidence is not quite clear. I think most people agree that it helps you with that task, so you get very good at that task for that whatever that task is. So is it Sudoku or doing crossword puzzles? But it doesn't necessarily translate to other areas. So that's the challenge. So there's dispute about that. So it's not consensus. Yeah.
I didn't mean luminosity, for example. I meant new, different things all the time.
Yeah. No, so I think there's a consensus that we do recommend that. I think that's hard to, because it's such a general thing, right? I mean, definitely I do too. I recommend, learning new languages, learning new instruments, learning, getting new experiences. But do we have solid evidence that reverses or delays dementia? We don't. So I can't say that. So it may, but it's a hard thing to study unless you have a very specific intervention and you can randomize versus a control. Sorry, there's one question in the back first. Yeah.
I just understood that there were some epidemiological studies that showed that certain categories of people, for example, crossword players, dancers in particular, I understand, have a later onset for dementia than the general population.
Yeah, I think there is some evidence for people if they are doing the activity pre-morbid state. So that's different than treating dementia itself. So what I'm talking about is treating dementia itself by the time you have dementia. And even with mild cognitive impairments, it's not clear whether we can do anything to reverse that risk, but definitely we still encourage people to exercise, without a doubt. But definitely, I think, the recent evidence has supported pre-morbid, if you're at risk, having a healthy lifestyle, controlling blood pressure, controlling cholesterol, but definitely exercise. So that's the most recent evidence, large studies looking at exercise, and that really reduces your risk. So I would agree with that, but it's different preventing versus once you already have it. Yeah, exactly.
So I was going to talk about that particular study that you were saying. So there's a Stanford article. I think the title is like Dance Make You Smarter.
Is it what, sorry?
Dance Make You
Dance
Smarter.
Make You Smarter.
From that Stanford
Sure,
article.
yeah.
And so that is a 21-year study from
Yeah.
1980 to 2001, and published in 2003 in New England Journal of Medicine.
Mm-hmm.
And they track all activity like walking, biking, running, golf, tennis,
Right.
swimming, and then daily activity like solving puzzles, listening to music, reading and writing. And it turns out dancing was the only physical activity shows the result reducing dementia.
Yeah, so the more recent studies have shown that just any type of aerobic exercise probably helps if you're at risk for dementia to delay that onset.
Yeah. So they said it was the synchronization of the music.
Yeah, so that may be true, but definitely recent. So I don't say that's wrong. I'm saying that there is generally evidence now to show that exercise in general is helpful. So there may be something extra you're getting from the dancing. I don't know. Yeah.
They said it's rapidified decision making on the back because the
It may be. Again, this is the challenge with these studies, right? Then you develop, if you see an effect, you develop a hypothesis why there's an effect. But it's really hard to prove that a hypothesis, right? Without doing really repeated studies, extensive studies, right?
Yeah. So that one they can only claim prevention. They cannot claim reverse.
Yeah.
And then the study that I mentioned last year, that was claimed for the first time able to reverse.
Yeah, I'm not familiar with that study. I mean, but definitely there's no consensus on any treatment that reverses Alzheimer's, any dementia at this point. Yeah. Mm-hmm. So, a big factor related to dementia is loneliness and depression, especially aging at home. People start to age. I have a patient just this past week came and was talking about, geez, I lost all my friends. They've passed away. This other friend has, moved away. This other friend is dying of cancer. So loneliness and depression, related features can really impact. You can have, of course, pre-existing depression. So if you had a lifelong battle with depression, of course, that continues. But of course, you can have new onset depression as well. But these are all things that we really need to be aware of. And it's not a specific consequence of aging itself, the aging event. So this is something that is manageable, treatable. So we definitely want to screen for that because it results in comorbidity. You get impaired function. You utilize health resources more, and increasing mortality, including suicide, but also disease-related mortality as well. So this is important. I think this is something that we can really. I did a home visit on a patient last month, and this is a big factor. She's at home alone most of the day, other than the health aide who comes in to help her bathing, but not really much social interaction. So and there's definitely clear evidence that social interaction can help with depression and prevent depression. So this is interesting. Depression is common among many groups, right? The general adult population, community elderly, maybe less in the general population, but if you look at people with disease, so comorbidities, Parkinson's, heart attack, stroke, cancer patients, geriatric inpatients, people are hospitalized, it's fairly prevalent. So there's this kind of correlation there that we want to be aware of because it's something that's manageable. So a lot of risk factors for depression in later life. Female, socially isolated, if you've been widowed, divorced, separated, lower socioeconomic status, again, comorbid conditions, pain, of course. Pain, uncontrolled pain is terrible at any age. Lack of sleep, functional impairment, and cognitive impairment. So definitely we want to screen for that. So what are the tools we use for screening? So these are just a few of the tools we use for screening, the physicians use. So we have 2 questions, so very simple things, very simple questions. Geriatric depression scales. PHQ-9 is used across the board, but that's basically a little bit longer series of questions. And there are many, many other screening tools. So this is important. I mean, of course, people can self-administer, but we really, in primary care clinic with our residents, we're really teaching the residents and the students to be aware of this and start screening all patients, but especially older patients with multiple chronic illnesses to screen them for depression. So the treatment is the same in the older population and the younger, but I think the biggest takeaway here is medication needs to be more carefully managed in the older population. So you want to make sure that they're taking their medications, the compliance is there, they're not taking excessive doses, watching for side effects, interactions, so more complicated there. But all the kind of usual treatments for depression. So for hearing loss, age-related hearing loss is very common, 43% of the older population. It's quite amazing. So multiple etiologies. You got sensorineural, basically your inner ear, the auditory nerve. That's probably the biggest reason people have hearing loss that's age-related. But you can also have conductive loss. Of course, there's an easily treated reason, wax, so that's fairly common. So everybody should get an ear exam. Audiometry is helpful to diagnose, but it's probably not so helpful in that we have limited treatments, right? It's mainly hearing aids. The biggest challenge of hearing aids are twofold. One is the kind of social issues. There's social stigma. Some people feel to wearing a hearing aid. And 2 is nobody has solved the noisy restaurant problem. So the noisy restaurant problem, you're in a restaurant, it's amplifying everything. And as you get older, it's more difficult to distinguish, to separate out background noise from the sound you want to hear. And there are many reasons for that. We don't know exactly why. Some people think also the hearing aids are impairing our localization ability because the timing is off. Because we have this interaural, we're very good at detecting tiny differences, not consciously, subconsciously, of time arrival of hearing, of sound to our ears. That's how we know if something's coming from here to here, right? If we had one ear, it's much more difficult to localize sound. So these are something that technology is developing. Hearing aid, interesting. So there's this battle going on now. And I hear it's changing. I didn't look it up, between hearing aids and personal sound amplifications. From a technology perspective, it's essentially the same thing. So, audiologists have carved out this special niche where only they can give, in most states, hearing aids, and thus the hearing aids are super expensive, right? So they're trying to fix this issue. The problem is, it partially also stems from, it's all cash pay, typically not covered by most insurance. Medicare doesn't cover hearing aids. So, some great store figured out, hey, this is a great business, and they're now the #1 hearing aid sales channel in the country. Do you know who sells more hearing aids than anyone else in the country? Costco, by far. It's like 20 or 30%. Yeah, because they make it easy, it's cheaper, you go there, they've got the audiologist there, you go there, you can get everything done, and it's cheaper, still expensive, but cheaper. So something, I usually recommend patients go to Costco just because it is so much cheaper. But I think if you're ready for a hearing aid, if you know somebody, frequently people, the person who's got the hearing issue doesn't care, and it's the family who complains about it. The spouse, the daughter, the son say, God, the TV's on so loud, or I got to yell, and so that's you got to be aware of that as well. But with the hearing test, if they're not going to do anything about it, probably not that useful in my opinion. I think some people just want to know, but if you get the audiometry, it's fine. I mean, if you're looking for something else, that's fine. But there's some fancy new personal hearing sound amplification devices. That's something recently with smartphones, they've come up with a lot newer devices that work quite well. And you can even tune them by frequency, which was kind of the initial selling point for the hearing aids. They would take your hearing profile and really tune it for the frequencies you have difficulty hearing. But of course, most people lose high frequency hearing first. So usually you have a pretty flat curve across all frequencies, and then it kind of drops off as you get older. So, it's not that difficult to help tune those devices yourself. But, nobody solved the noisy restaurant problem. But interesting aside, there's in U.S. but also in Britain, they've used this problem to their advantage. So some stores which have teenagers hanging around too much. So to scare the teenagers away from loitering, they would play a high frequency sound that only the kids would hear. So they would get really annoyed and they would leave and nobody else would hear it. Because we lose I can't hear high frequency sound. It doesn't bother me. So let's go on to vision. Cataracts, glaucoma, macular degeneration are probably the top 3 age-related problems. Those are important to detect, can really affect your vision, especially night vision. So that can affect driving. So you see a lot of older people, they really don't like to drive at night because of, somewhat related to these issues. But also, presbyopia. So that's something that I hate to say I've experienced. It can start at 40. Basically your eye, so this is the eye, the lens. The lens gets stiff over time. And you have your ciliary muscle and you have these fibers. And so that's how you focus. That's part of how you focus. So it's different than, myopia or, nearsighted, farsighted. It's actually your inability to focus close. So, those ciliary muscles will relax or pull your lens and try to change the shape of the lens so you can see closer. And that lens gets stiffer as you get older, so even by age 40, you start to have difficulty accommodating with your ability to accommodate with closer vision. And then that can get worse and worse. But usually at some point it does kind of flatten out at some point. It tends to stop because, there's only your lens is already so stiff and it's probably not going to get any worse at some point. But definitely, I think the big takeaway here is get annual eye exams. Especially if you have chronic, glaucoma, chronic macular degeneration. Of course, you're probably already getting treatment depending on the type you have. And cataracts, helpful to monitor those because they're treatable. But especially with disease-related illness like diabetic retinopathy, which is important to get annual exams. So it's good to be good friends with your optometrist or ophthalmologist. Skin issues. Oh, I'm way over. I'm getting close. I've got a ton of slides and I'm still way over. Talk about skin issues. So dry skin, very common. Itching, easy bruising, skin tears are very common. See people all the time, especially if they have minor falls. Benign growths, sunspots, age spots, seborrheic keratoses are common. Pressure ulcers we worry about. So that's really associated with a high morbidity. And skin cancer. So you got to have regular skin checks. So very important, very important. Either with your primary doctor or with your dermatologist or both. So if you look, just carving out pressure ulcers, so this is a big problem with people who are more bedbound, not as mobile, sitting in the chair all the time, the wheelchair or in their bed. Pressure ulcers are very common, especially in nursing home patients. So this is something that's addressable that the U.S. has really been focusing on in the institutional setting. But awareness at home is very important. Again, at home visits I've done, I have patients who are really immobilized, or have very limited mobility, been close to developing pressure ulcers. So it's really important to monitor for this. So nutrition, I really, hard to get into detail about this, but I always recommend people develop a customized nutrition plan because there's so many details with this about how you're eating, what you're eating, so forth. But just a couple of red flags to be aware of. Unintentional weight loss, that's concerning. So, be aware of that. So that's something that some people just say, well, I'm getting older, I'm losing weight. That could be a sign of a serious disease. So bring that up to your doctor. Talk about what you need to eat, what your calorie needs are. Talk about supplements. That's, some people start supplements like Ensure themselves. You may not need it, so talk about it with your doctor. You may not be taking the right supplement. Another red flag, choking or gagging. So this is aspiration risk. So basically, if you're eating, swallowing food, it may go in your trachea, in your lung. That's really concerning as you get older, especially if you've had a stroke or you have other diseases that may predispose you to this. If you have movement disorders, Parkinson's, because you can develop a pneumonia very quickly, and that's a big reason to be hospitalized. So if you have any choking or gagging, difficulty swallowing, bring that up to your physician. And just to be aware, Medicare covers nutrition consults for many patients. So, it may be covered for you, especially if you have high cholesterol, diabetes, coronary disease, obesity. So many diseases, they'll cover a nutrition consult. Constipation. So this is a hugely prevalent problem among older adults, up to 50%, depending on how you define it. A lot of people use laxatives. Slow transit is one main reason. You've got difficulty expelling stool from the rectal vault. That's another reason. And some people with irritable bowel type syndrome, so we're just like chronically constipated. Should be evaluated. And a lot of treatment, I always tell people, make sure you're getting enough fiber. You can take your fiber supplement. Drink plenty of water. That's a big problem a lot of people have, if you can, unless, if you have other medical problem where you can't drink water. And make sure you move. So moving helps bowel movements. So moving. So this is a common complaint, very distressing. Laxatives are frequently used. I won't go into the details of these. Stool softeners, other medications. So probiotics don't directly treat it like on a case-by-case basis, but there is some thought that may help your bowel motility over time. Again, this is something that's been hard to study because standardizing probiotics, what probiotics you test, there's so many different ones. So, if you ask if there's a consensus, I would say no, but I tell people it doesn't hurt, probably, for most people. And, a lot of probiotics come in a tasty form like yogurt or, whatever you like. So it probably doesn't hurt to try. But if you do try probiotics, you have to stick with it for months. It takes months and months and months to change your microbiome typically. It tends to change when you don't want it to change, and it doesn't change when you want it to change. So, like you take antibiotics, and then it's all screwed up. But when you want it to change, then it doesn't want to do it. It's like kids, right? Incontinence is a big factor. Bring it up to the doctor. So this is very underreported, both urinary and fecal incontinence. So that's one thing a lot of people just say, well, I'm just going to use diapers, I'm going to use pads. But bring it up to your doctor. It may be a treatable cause. It may not be, but definitely talk to your doctor about it. What screening tests should we do? So there's a whole slew of screening tests. So a lot of people will go to their doctor and then they'll get either the initial Medicare preventative visit or the annual return Medicare preventative visit. So people assume that's a physical. It's actually not just a physical. It's a physical plus a checklist of things that Medicare will pay for. A lot of those things probably are not applicable to everybody. So, you got to pick and choose what you want to do. But, definitely there are a few basic things that most patients should do. So getting screened for diabetes because of the prevalence. Talk to your doctor about aspirin for primary prevention. For women, it's primary prevention for stroke, according to the U.S. Preventive Services Task Force. For men, it's primary prevention for heart disease. Different if you've already had a stroke or heart attack. So that's called secondary prevention. So it's a little complicated issue. Talk to your doctor. Immunizations are very important. So this is something that can prevent a lot of disease. Tetanus, in particular with the pertussis. So a lot of older people haven't had the tetanus shot with the pertussis. So California, there's been a recurrence in the U.S. Every few years there's 10,000 cases. So whooping cough. So make sure you get that Tdap if you haven't had that as an adult. So that's a newer recommendation. And you may have seen on TV the pneumococcal vaccination. There's a new recommendation to get both types. So a lot of people think it's a new vaccine. It's actually not a new vaccine. It's just that they're newly advertising it because now they're recommending doing the 13-valent vaccine, which is called Prevnar, and then a year later doing the 23-valent. So that's a new CDC recommendation. Shingles is important. If anybody's ever had shingles, they say, I don't want to have that again. So people who haven't had shingles say, maybe I won't get it because I don't really care. But of course, it's only for people who've had chickenpox as a kid, and most people have had. And flu shot every year, there's huge mortality associated with flu shots. So, there's just some simple things we can do to really stay healthy. There's really not much downside. A lot of people are afraid of vaccines. And really, the evidence does not support that fear, unless you have a known allergy, a known vaccine reaction, right? Those are very, very rare, significant side effects from vaccines. Of course, appropriate screening for cancer. There's always disagreement about when to stop screening, so you have to talk to your doctor about that. But colon cancer, very common, preventable. Breast cancer for women, cervical cancer, depending on your age. Lung cancer, if you had a history of at least 35 packed years of smoking, there's a new new protocol, relatively new, of low radiation dose CT that's been shown to be effective in preventing lung cancer, early detection of lung cancer. Cardiovascular, of course, blood pressure monitoring, cholesterol monitoring. AAA is abdominal aortic aneurysm. That's for people who have smoked. You're at increased risk if you have a smoking history, even a small smoking history, which is interesting. Osteoporosis for women. The evidence is not there behind men to screen men for osteoporosis. New recommendation for the CDC to screen all baby boomers for Hep C. And then HIV is recommended for everybody to be screened at least once in their adult life. But, in older people, if you're not sexually active, of course, there's no risk. So, it depends on the population there. Tobacco cessation and talking about alcohol, drinking a moderate amount of alcohol. Typically one drink for women a day, 2 drinks for men a day at most is the current recommendation. But of course, the interactions with medications are significant, especially for older people. So you need to discuss that with your doctor. This is the biggest issue I see that's preventable. Medication use, interactions. So you really need to I tell people just bring a bag of their meds. Just bring all your meds, because you never know. Sometimes you write it down wrong. Sometimes you don't remember. Sometimes there's some confusion, or maybe they prescribed it correctly on the bottle and you're taking it differently. So just bring your bag of meds every visit. The doctor will love that, because we're required to do medication reconciliation. So basically, what that means is checking our med list versus what meds you're taking. So a lot of people just do it by memory, and I've seen a lot of errors. I think one of the pharmacists mentioned to us in this project we're doing that every time he does MedRec, he catches 1 or 2 errors. And I'd say in my experience, that's probably true. It may be a small error, just like a duplicate medication, but it's still an error. Yeah. Review it with your pharmacist. Take advantage of your pharmacist. They're not just there to, sell you Diet Coke in the aisle number 3 or whatever it is. You can actually consult with them and talk with them and ask them questions. Ask your doctor whether you can stop any medications. A lot of people just have medications there for a long time, and we make a lot of assumptions. We say, oh, well, they're on it because they still have their reflux. Comes up with medications like Prilosec. But, medications like Prilosec in the long term, if you don't need them, do have side effects and increased risk for certain problems. So, you should talk to your doctor about doing those if they can be stopped and get their opinion. Keep an up-to-date medication list. So, of course, you're not going to bring all your meds with you, but you can keep your list with you. But definitely, I still recommend you bring all your physical meds with you. And, now, like at Stanford and most places, when you leave the clinic, they'll print you a list of what we think your medications are. So, make sure you have that list with you. Ask about adverse events, what side effects are for the meds. So ask about them, interactions, and ask about alternative medications that may be lower cost. So you may be able to save some money, because a lot of these things we're just kind of picking one in the class, and we're not necessarily have any particular preference for one. It's just one, out of habit we tend to choose the same one in that class, but it's not always covered well by your insurance. So ask about that. So a couple of things, I'll run through the list, and I know I'm over. Home safety, I think that's really key. With my home visits, I do this a lot. A lot of it's common sense. Avoid rugs, trip hazards. Make sure you have the appropriate railing. Make sure, the steps aren't loose, nothing's, a trip hazard, the threshold, non-slip surfaces, commode issues. So a lot of times the toilet's in a funny place. It's hard to get up, so you see a lot of falls in the bathroom. There's a lot of hard surfaces in the bathroom for you to whack your head. So make sure you got enough rails and things. It's not going to hurt anybody to have a couple extra rails in their bathroom. Making sure the bed type and height is appropriate. Some people have way too high beds and they slide off. Some people need a hospital bed and don't know to ask for it. So definitely if you have difficulty with mobility, that may be appropriate for you. Fire hazards, so that's really unappreciated. So people leave the stove on. Things catch on fire. If you're not cooking, you may not need a lot of this stuff. Or if I had one patient, all she was doing is just reheating she was just boiling her water for her tea. That's what she's doing. But she had a gas stove and she was losing her memory. And I was like, just buy an electric kettle. So she's happy with that. So they turned off the gas, electric kettle, didn't need the stove anymore. None of the dangerous gas that could explode if she left it on. And then, think about a medical alert, all these little buttons, different companies. I don't have any preference for anyone. But, a lot of patients have found it very useful. They've fallen, and like the old commercial said, they couldn't get up, and they push the button, and the paramedics come, or usually the firemen. And it's funny, some of the firemen, they start to to know the people who fall, and they know them, and they come there and they get them up and they evaluate them, and they usually don't have to. A lot of times, they don't have to go to the emergency room, but it's helpful. I mean, you don't want to be locked in your house for days and end before somebody finds you. Driving. So this is the thing. It's hard to take people's keys away to really talk about that. So really bring it up if there's any concern. Of course, red flags are people who are starting to get in accidents, getting more tickets. A lot of times they present, because, we as the physicians, we don't see people drive because somebody's already done it. Somebody's already reported them to the DMV, and the DMV, anybody can request a kind of somebody to be evaluated. The police officer can, the doctor can, and they'll usually come with the form and say, I may lose my license. And then you say, hey, let's talk about this. So it's tough, but we live in this modern age. So Uber, I had a patient just this week. She was so mad at me. Her son and her came to my clinic, and she'd been in her second accident. Her car rolled over her ankle the first time, and then the second time she ran over the median. And I said, now's the time to stop driving. She was so angry at me. Now she's so happy. She's like, Uber, great. She takes Uber everywhere, not expensive. She probably ends up paying less than the cost of maintenance of the car because she didn't drive the car far, but she's got to pay the insurance, she's got to pay the upkeep, all those things. She doesn't have to worry about it, so she's very happy. So take advantage of modern technology.
Uber had a service specific out there.
Yeah, so there are a lot of people working on that. So Lyft is working on that, Uber is working on that. There's a company locally called Silver Ride. Of course, there's the services like, Ready Wheels, Paratransit, things like that, if you qualify. But it's difficult to lose independence. One thing you can request, the neurologists here in the memory clinic, they actually have a driving simulator, which is relatively new. So sometimes if they're a little concerned, but it's not clear, they'll have the patients do a driving simulation there. Yeah. If I'm not sure, usually I'll say, well, I'm not sure, but I'll ask the DMV to make the patients do a road test. So a couple other things, and then we'll finish up. Hospitalization is very important. So elderly, high risk for readmission, high risk for all these all these hospital-acquired conditions, and they often require a higher level of care at home when they're discharged. So transitional care is really important, and that's the project I'm working on with Theo, who's sitting back there. We're doing an app that's basically doing care coordination, so in and out of the hospital. So anybody who's interested in that, let Theo know. He's got some information on that. But it's really an important issue because that's, we think that's preventable, right? If you get readmitted within 30 days, we're like, well, we didn't do our job in the hospital, something happened, or something didn't get arranged. So that's a potentially preventable admission. Wanted to talk about this, home care. Home health is, some people need it by the time if they have difficulty with assisted, what we call activities of daily living, ADLs, bathing, cleaning. Home health aides, usually cash pay, insurance, Medicare doesn't pay for this. They come usually, as often as you request them. Some people ask for a few hours a day, some people ask 24 hours a day coverage. You're typically not licensed people, they're just, people who've been hired for this. They don't have any clinical licensing. Usually, they can't, sometimes the services will have a nurse come out every once in a while. You can have separately having visiting nurse come by. Long-term care insurance can cover part of that as well, depending on your long-term care insurance. When people are living at home and they really can't care for themselves, then people talk about, what's the plan to go to a facility, assisted living, definitely better developed, huge range of skills and services. So definitely you want to do your homework, because some facilities are very different than others. So you want to go there, and it's difficult to choose one. So that's something that a geriatric care manager can help you with. So some people hire geriatric care managers to help them both at home and choosing assisted living and managing care. So that's something, to look into. There's lots of resources there for choosing, but, definitely talk to your doctor. They may have a social worker. They may have, like here we have adult aging services, who's great at really helping people with that decision. End-of-life planning, this is very important. So I know I jammed it in at the end, but there's so much to talk about. Advance directive, very important. So that really, the key thing for that is it establishes a power of attorney. Who's going to make decisions for you or your loved one if they can't do that anymore? Important to also talk about a financial power of attorney, while you're having the same conversation. And There's something else, this pink form called a POLST form. So this is state specific. That's physician orders for life-sustaining treatment. That's very specific instructions, whether you want to be resuscitated, intubated, you want nutrition, you want comfort measures. So talk about that with your doctor. People think the advanced directive takes care of that, but that's, whoever's your POA, they'll take care of it. But that's based on what you talked with them about. The POLST is much more specific. So if the paramedics come to your house and they see you're, incapacitated on the floor and they see the POLST form there, that's why it's pink on your refrigerator, and they'll figure out what to do. So talk to your primary doctor, social worker, senior villages like Abanitas locally, senior centers, eldercare.gov is a good source. Geriatric care manager is another thing you can consider. So lots of resources out there. There's more resources than I can put up there. AARP's got lots of resources on their site. Mayo's got resources on their site. But I just wanted to close with this. So it's another Rembrandt. So this is from the same columnist. Rembrandt's deepest study of aging was a lifelong project. He watched himself grow old. His unrivaled and sustained self-portraiture shows how he himself changed with time. As he ages, he sees himself more intimately. He stops pretending to himself. To compare his self-portraits at the ages of 34 on the left and 63 is to witness someone grow in suffering and sorrow and perhaps wisdom. At 34, he looks proud. At 63, he simply looks human. So just to leave you with that word, and thanks for your attention.